Hi, I'm Teddy Bear. And this is my friend Mechmedic. Mech runs a TCCC course here through Brushbeater and allows me to come along and get in the way underfoot and nerd out about calcium and the clotting cascade. So what we want to talk about with you is the Krebs cycle. No, thought we'd do a video just kind of discussing tourniquets. This is one of those that's here at the Brushbeater.store, and I'm gonna hurt some feelings taken out of the wrapper if I can. Now imagine. So here's lesson number one. Should we store our tourniquets in the wrapper in our eye packs?
Yeah, and this is kind of a common thing that gets brought up a lot, is storing them, and it's something I saw pretty commonly when I was still in, is that guys would just kind of throw these, especially when they were brand new. They would leave them in the wrapper in their pouches, and he's struggling now, and his hands aren't.
Can you stop bleeding, please?
Covering and stuff.
Yeah, that's dry.
So you want to take them out. Like I have one here that's just on a little fanny pack by AWS that I have. That I have an IFAK in here, and then I have my one accessible tourniquet, and then on this one I have one here as well. And this keeps it enclosed. Generally, you want to keep them enclosed in something. So whether it's this pouch that he has, or like with this one with the MFAK, having it inside the pouch. The reason that this one's not is because how this would be sitting on me is it's pretty well covered from sunlight, because UVs are big concern for this, is they can wear down. The Marine Corps actually had some pretty big incidents of this in Kandahar province in 2016, I think it was. They had a bunch of them break prematurely because they were carrying them in what's called the diver's triangle, which is kind of anywhere from shoulders to belt buckle, where you can get to something with either hand. And so they were wearing them on their non-dominant shoulder, just kind of bungee to their IOTVs. And so they were being exposed to a bunch of sunlight in the middle of summer, and that was causing them to deteriorate and break down. So we kind of want to keep them out of the sunlight. So whether it's a fully enclosed, like specific tourniquet pouch, this is the same thing as this. It's just a newer generation, a better version of it with the everyone's favorite laser cut.
It is laser cut, so it's better.
It's better.
So one issue about this, I understand the rationale. Stella, be quiet. I understand the rationale of wanting to protect your tourniquet.
Yes.
I'm not a huge fan of having a tourniquet inside the IFAK.
So that's why I generally recommend having a secondary one outside that's easier to access to. And that's for
you actually could do that.
You could,
because this has webbing on the outside.
Yeah. You could either just lash it with some bungee cord, or there's some companies that make products.
Yeah.
If you want a consumer out.
And honestly, like if you did take that out and you have the space, you can take, like, whether you have quick clot, something like that. If you specifically need quick clot because you have a budget for it, or you have like you have atrial fibrillation and you're on Xarelto or other blood thinners, and you need something like this. Well, like this is $53. Compressed gauze like this from NAR, North American Rescue, is about $3 to $4. Now, this does work better. Does it work 10 to 15 to 20 times better? Well, again, if you have special circumstance where that's relevant, sure, that's a judgment call. But I'm distracting myself. Point blank, if I took this out of here, I'm going to fill that space with something, which is probably the answer is more glass. It's probably the answer.
Could be. I'd probably honestly leave that in and just get an extra one just to have it outside.
2 tourniquets is also not the bad answer.
Yeah, it's always better to have an extra. So inside this, I do have, or do I not? I do not. I'm a dirty, filthy little liar. I thought I had an extra tourniquet in here. Okay, well there goes that.
Yeah, we find out something.
On camera, exposed as a fraud, live. But generally, I have extras on my kit as well. So if I'm wearing this for like a chest rig or a plate carrier, I'll have extra tourniquets on me. This is just as a dedicated thing for if somebody else is grabbing. Everything is all in one place. But you can even see here on this bag, I have one here along with another IFAK, because you can never have too much medical. So I'll always, even if I have, I generally don't like mounting them to chest rigs. It takes up too much room in my opinion. I think, and this is just me personally, chest rigs are for supporting the fight. This is for after the fight.
Well, I mean, nobody ever got shot while not carrying a weapon.
Right.
Right. So just the whole point of like having your, I'm being sarcastic obviously, but the whole idea of you got that first line kit, and you can argue this is like first line and a half, but if you had your med kit on you all the time, if someone decides, hey, we're gonna fight, and you were not told, so you didn't come prepared with all the party favors, you still have your IFAC. So at least someone can work on you even if you were not an active participant in the party.
Yeah. And I prefer this over belt mounted, because if I have to wear a rucksack, and there's going to be people that can say that they can wear belt mounted stuff with rucksacks just fine. They have Gumby torsos. I do not. I don't have an extra long torso, so my space is limited. So I like to keep this like a fanny pack for my IFAC, specifically for that reason. So whatever I'm wearing belt, whether it be an actual like a Salter's belt, or if it's a rucksack, this doesn't interfere with it. So regardless of what I'm carrying, I can always have an IFAC, and it's in the same spot. It's in the same piece of nylon, so it's in the same spot everywhere I go.
Can't I always just improvise a tourniquet on the spot? I mean,
so you can. The problem is that they, through some studies, they found that they have a 50% fail rate, and that's generally not something we want to go with. I know the Han Solo school of thought is don't tell me the odds, kid. But that's not really, like 50% odds is not something I want to play with when it comes to bleeding control.
I think it's a really good thing to know how to do.
Yeah.
At the last SOMA conference for the Cadaver Lab, they ran through that. It's like, all right, we have let's take I'm blanking on the term again, the military cravat.
The cravats, yep.
And doing the whole, and we should definitely do a discussion of that at some point as far as how you do an improvised tourniquet. But, when it takes you, given an adequate blood vessel compromise, it takes you 3 minutes to bleed out, and less than that to lose consciousness and not be able to help yourself. So you probably don't want to be doing arts and crafts while you're losing blood, or while your buddy is losing blood.
Yeah.
So, hey, miracles of modern polymer, we have these. If you're very resource limited, there are places, there are websites where you can get the files to 3D print the parts, and you can make your own webbing. But hey, if you have access to these, it's like usually like $25, $30 for a tourniquet. That is basically about the cost of going through a drive-through twice. So, could save your life. Because you don't necessarily have to be carrying a weapon to be victimized where you need one of these.
Absolutely.
So tourniquet really is all I need. I mean, it's like basically just put it on high and tight, and I'm good, right?
If only it were that easy.
If only it was so easy.
Yes.
Halo vibes.
That's what I was going for.
Thank you. Yes. We're old.
So tourniquets definitely play a pretty big part in pre-hospital trauma, but they're not all. The number one cause of death for adults under the age of 44 in the U.S. is trauma. The vast majority of that is due to some sort of massive hemorrhage or massive bleeding loss, not massive blood loss, I should say. Not all of that is something that you can apply a tourniquet to, so it has to be an extremity, except for the head.
Do not tourniquet the neck. That is called strangulation. But yeah, so basically if you've got something past here or past your thigh, kind of common sense rules apply here. If you can get a loop around it, then you can tourniquet it. If it's into the trunk, that's a whole other problem set.
Yeah.
But this is going to cover a lot of those extremity injuries. I mean, our extremities are on the outside of our bodies.
Yeah.
They tend to be what gets injured first. Unless someone's specifically aiming for center of mass, and that's just a whole different problem.
Yeah, there's a whole set of statistics and data out there on the wound sets and where combat casualties are kind of where they're coming from versus like where that injury is located, and extremity hemorrhage is a good chunk of that, and the easy answer for that is a tourniquet. sometimes it's not something in a spot, even on an extremity, where you can put a tourniquet on, and that's where like the packing gauze or the quick clock come into play. So if we look at this trainer here that we have, you have this one, you have two different wounding locations on this, hence the two different pieces of tubing that we can attach fake blood through to make this a wet packing trainer.
We tell them it's fake blood.
And so you can put a tourniquet on this trainer. You have enough space. You have 2 to 3 inches to go above on both of these injuries to place your tourniquet. But the problem with the tourniquet is it restricts all downstream blood flow, whereas with a wound packing, we're not restricting the blood flow for the rest of that extremity. This is a big thing they're seeing in Ukraine right now, where you have a lot of unnecessary amputations because tourniquets are being applied and left on when that's not necessarily the correct intervention. And you need to convert that tourniquet to a wound packing or even just a pressure dressing by itself.
Or they're being applied inappropriately.
Yeah.
Sometimes there's something called compartment syndrome, where if you don't put the tourniquet on tight enough, it allows blood flow to get past, but not come back, and then you basically increase all the pressure in the compartments of the extremity downstream. And now, if you weren't going to lose that limb before, you are now.
Yeah.
So it's very important to know when it's appropriate and how to do it correctly. So how do I pick a tourniquet other than like, you know what, Matt, Brushbeater sells these must be good to go, which is a fair statement, but why does he have these in stock?
So the North American Rescue Combat Application Tourniquet, or more commonly known as a CAT, this is the Gen 7, this is the most recent generation, is on what is known as the Committee on TCCC recommended list, recommended, not approved.
We'll call it COTSI from now on, because
yes.
nobody wants to say
So
that and all that.
They're an organization that belongs to the DoD, made up of various levels of providers, going all the way from just general line medics all the way up to different types of surgeons and everything in between. They've done a bunch of studies. The most recent one was in 2019. And that is, there's like 7 or 8, they'll probably add in a little thing somewhere around here of what the actual number is of recommended amount, or the amount of recommended tourniquets. There's a lot. There used to be, when I first started learning, there was only 3. It was this, the Soft T Wide, and the Delphi Medical EMT, Emergency Medical Tourniquet, which is this monster, like blood pressure cuff looking thing. Very, very cumbersome, but also extremely expensive. But this is one of and this has kind of become just the standard.
It's kind of the Glock 19 of tourniquets. It's not everybody's favorite, but it works well.
In service, I mostly only ever saw these. I saw Soft T Wides outside of a training environment once, and that was looking through another unit's MES set. There was a bunch of Soft T Wides, and actually, ironically enough, a Delphi EMT was in there as well. So that was pretty cool to get to see those. But by and large, you're only ever going to see these. These are what are getting ordered. These are what the majority of people are training on.
So I can go on Amazon and I just need to search Cat 7. I should be good, right? Like, I mean, sometimes you can get really good deals. There's like ones for $5. So
the problem is that thanks to Airsoft, there are a lot of counterfeits that have made it out there. A lot of guys want to look like really high-speed dudes for when they're shooting plastic BBs at each other, which whatever you want to do in your own time is fine. The problem is that some of them have actually even made it into the military supply system. They're getting very good now to where I wouldn't trust them even from the NAR store on Amazon. I would only buy them directly from North American Rescue or one of their licensed distributors, which Brushbeater.store is one of their licensed distributors. So these, you know, if you're buying it from Brushbeater or any of their distributors or direct from NAR, you know it's the real deal when you're buying from those websites specifically and not on Amazon.
Yeah, and the thing with it, it's not that the North American Rescue Amazon store is trying to rip you off, but whoever's fulfilling that order is an Amazon employee. They're just pulling stuff out of a bin, and if it looks the same, they don't know or care. They're just trying to move on to their next thing that they have to do. So we kind of went through purpose of a tourniquet, what you're looking for in a tourniquet, what you're got to be cautious of with a tourniquet. How do we use this?
So for applying a tourniquet, they get applied. So we talked about the committee on TCCC, Tactical Combat Casualty Care. Tactical Combat Casualty Care is kind of the overall set of guidelines for trauma medicine, specifically in a military doctrine. And it's broken down into 3 phases: care under fire, tactical field care, and tactical evacuation care. And there's 2 different ways that we apply these tourniquets. There is hasty, which is only ever done in care under fire, and that is a high and tight tourniquet directly over the clothing. We're not exposing, we're not trying to see exactly where that bleeding is. The reason why is if you have all of your clothing on, we're not going to know exactly where that wound is, but if we're care under fire is defined as like there's still an active threat going on. So we don't want to take the time to sit and expose and cut everything off to figure out where that is, because there's still a threat to ourselves and our casualty that we're treating. So we want to get them off of that point of injury or get them off the X as soon as possible. So this is why we do the hasty tourniquet at that stage, and then we will get them off of that point of injury and get them to a casualty collection point, or a CCP, in order to
the goods kind of CCP.
The good kind, the one we like.
Not the one with the red flags.
That way we can reevaluate and get into the next stage of care and see if that's actually the correct intervention that we need. In tactical field care and tactical evacuation care, you do not apply hasty tourniquets because we have the time and security provided to be able to take the time and fully expose and fully identify the wound to apply it properly. So for a deliberate tourniquet, there's 5 characteristics of a deliberate tourniquet, and that is 2 to 3 inches above the wound, not directly over a joint. So like right here with this leg, we have a knee. So with this one right here, we don't want to like cover over. We want to go up above it because we don't know how far. So like this one comes in, you can see some of the external bruising on this model coming up to here, but I can get my finger in up to here. So we're not going 2 to 3 inches from the visible wound. We're going from the edge of it, we're going 2 to 3 inches above here. So we would want to place that tourniquet up about here towards the top of this model.
So
we don't want to go over the joint because that can cause a lot of unnecessary damage to that joint.
There's a couple of other reasons as well I just want to touch on. If you look at a joint, if you look at the bone structure, I'm going to be a little bit anatomy nerd on you. So not only are we trying to protect that joint, but we also want to get good compression, because if we, as I fail at tourniquets. If you look at like Google, go on Google, pause the video, get on Google, look at the way a femur is, like the big leg in the big bone in your leg is shaped. In the middle, it's very cylindrical, just like a stick, but on the ends, it swells out to make your knee joint, and then the next bone comes together like that. So you've got this wider part, and so if this is like my hands are the knee joint, for example, this we can compress against very nicely. We have an artery disappears somewhere inside this structure, like between my hands, between my knuckles. We can't compress that. It's into a joint, and we really can't compress those bones to cause a good compression on the blood vessel.
Yeah.
That's the other reason that we don't compress over joints. Now, there was this whole thing in like Black Hawk Down where they're talking about the artery, restricting, moving back up into the leg and all that kind of stuff. Maybe. What does happen is bullets do strange things.
Yes.
And sometimes, particularly if you think about like an isosceles stance with a pistol, if you take a round this way and it comes down your arm, who knows where, like the entry wound may be up here, but who knows, it tracks along that bone, who knows how far that artery is actually compromised, or that vein is actually compromised. Same thing for a leg. If you're taking a knee from behind cover, can we move the camera real quick? So I'm just going to be from here. So this is my cover here, and and if I've got my weapon, I pop out. Now I've got my leg exposed. We're just going to focus down here. And I know I'm almost not exposed. I'm exposed here. But if you see this angle along where my leg is, if I take a round here, the entrance may be here, but that's going to track along my femur, and who knows how far up that's going to go. Okay? So that's why we don't just tourniquet at the wound. We don't just apply pressure at the wound. At the surface wound, we look for where the bleeding is actually coming from. Okay?
Correct.
So I just want to thank you for letting me touch on that.
To add a note for when you're editing this, when I made that Halo 3 reference, when I said word it's so easy, I want you to add the word.
No, I bet.
Into
I
that.
got you.
I want that. I'm requesting formally, sir.
Oh Lord.
So there's a couple of reasons why we do the placement where we have it. So that was the 2 to 3 inches above the wound, also not over a joint, directly on the skin. We don't want any clothing or anything underneath that, because that could, for a couple of reasons. One, depending on how like puffy that clothing is, depending on what season of the year, what part of the U.S. you live in. Even like getting outside of continental up in Alaska, like if you're wearing the marshmallow suits and stuff, doing stuff in the wintertime, that's a lot of extra fluff and can prevent the tourniquet from constricting properly. So we want to get it directly onto the skin, and we want it taped because we want to be able to ensure that it's fully secured. And then we also want to time it, and that is important because once it's properly applied as a deliberate tourniquet, we know that it's staying. That's starting a timeline for how long it can be on before drugs have to start getting applied or administered, before they can remove it when it gets to that higher level of care, or potentially it renders the entire lower appendage unsavable and it has to be amputated. And that higher level of care needs to know when that was applied, because it's very important to how they take it off, how they treat everything downstream of it, and how they handle that casualty.
So I get to talk about nephropathy and cardiac
Yeah,
arrhythmia now?
I mean you can get
Whatever.
that's your thing. And so that kind of like real quick to state, like, all of this is useless without that higher level of care. That's not to say we're not going to do it, because that's a common thing. We were talking about that the other day, that a lot of people get real doomer about this, and like, oh well, you know, you have to have like a full-on surgical suite in your back pocket, and you have to have all this sterile stuff and all these sterile fields to be able to do all of this stuff. Like it's not that important. Sterility is kind of a suggestion in trauma. Even in trauma care, it's a suggestion. So
as the great Master Sergeant Paul Howe, U.S. Army Delta retired, would say, that's what IV antibiotics are for.
correct, absolutely. So we're just going to treat them to the best of our ability, and kind of like if you've ever done shift work, that's a day shift problem. This is a higher levels problem. We're going to treat them the best that we can with what we have available, and shift. That doesn't mean we do shoddy work, but
There's some limitations.
there are limitations. Just
yeah, it's called pre-hospital for a reason.
there's just only so much that we can do. So we'll do what we can, and we'll let somebody else deal with the repercussions of all of this.
One point I wanted to make, going back to the hasty tourniquet, particularly over legs, is a lot of people will have these things in their pockets, and we'll have students come into class, and then we try to practice this, and the first thing we have to have them do is go ahead and take your phone out of your pocket, because hey, we don't want to crush your phone, but we're probably not going to get real good effect over a phone, over any kind of object in your pocket like that. So that's another reason to cut down the skin. I mean, general rule in trauma is you get them naked and just, hey, I want to see down the skin exactly what's going on.
Yes.
Because sometimes things hide out. So, okay. So I mean, yeah, let's say I won't. Sorry, I won't let myself get that sidetracked for now. Going back to how long do you get that question a lot? Like how long do you leave a tourniquet on? What's too long? What's too short? You know, what do I do? Generally speaking, it's not a light switch. It's not all off or all on, right? It's not the binary kind of thing. There's a progression. The tissues that are most likely to start dying the soonest is skin tissue, and that starts at 2 hours. The deeper tissue takes longer. The general guideline is you try, if you can, reduce a tourniquet, and that's going to be another video. When I say reduce a tourniquet, I mean, or convert a tourniquet. What I mean is to go from that high and tight to something else where we're minimizing the amount of tissue that we have with blood flow occluded. So we try to maximize the amount of body part that gets blood. So we apply our tourniquet. If we can, we try to get to the minimum tourniquet use within 2 hours. But if the tourniquet's been on for 6 hours, you do not remove that tourniquet. And it's not so much that we're writing off the extremity. We're not necessarily, it's not really our call to write off the arm or the leg or whatever. That's the surgeon's call. The problem is that tissue has started to die. And that can be and when those tissues, those building blocks of those cells and parts of those cells go back into the bloodstream, there are electrolytes. It's like Brondo from Idiocracy. It's got electrolytes.
It's got what plants crave.
Yeah, it's what plants crave. So you got potassium that has an effect on your heart. If you take a tourniquet off and a whole bunch of potassium that's been sitting in a vein suddenly returns back to the heart, that could cause rhythm problems in the heart. It could cause a heart attack, cause the heart to stop. The other thing that's not as immediately life-threatening, but could put them on dialysis for the rest of their life, is you have protein from the cells going, same thing. Those cells have been breaking down, and those cell components are now in the bloodstream. They go back and they hit the filter systems. There's 2 filter systems in our body, at least. The liver and the kidneys. And the kidneys filter that blood, and it's like any filter. If you hit it with particles it was not designed to do, like, I got longer hair. If I wash my hair in the shower, I clog up the drain after a while because that can't go through there. So those proteins cannot go through the kidney. They clog up the kidney, and then we get rhabdo and potentially, certainly an acute kidney injury, possibly chronic kidney disease or kidney failure. So thank you for bearing with me as I and now I will hold forth on anatomy and physiology.
No, it's really important. Anatomy and physiology is one of those things that you can never have too much knowledge on, especially when it comes to trauma. It's generally a good idea to have a little bit more than a basic idea of a lot of this stuff.
Particularly the more invasive your interventions are.
Yep.
If you're putting IO needles in, if you're intubating, you're doing cuts, if you're breaking skin, you should know the anatomy of where right where you're at.
Yeah.
You don't. This is not horseshoes and hand grenades. But
Yeah.
that's a different topic.
Otherwise, you go to do a chest tube and drop it into a spleen.
3 times.
Three times.
Seen the pictures. But they meant well.
Yeah.
And they could bill for it probably. That's the important part.
So these trainers are really cool because when we use them in class, and if you come out to class for the TCCC, and then eventually next year we should be doing the PLS class again, we'll actually have these trainers out. We'll be using them. And the cool thing about this one and the arm that we have is that both of these trainers, they're soft and elastic enough that you can actually use them to properly apply a tourniquet on, and it will occlude the blood flow downstream of that wound. So this one has a bunch of different tracks on it.
So why it has 4 tubes is it has 4 different wounds.
Yeah.
And there's a tube to each wound. So if we want to, basically we'll just cover, or otherwise basically just cover a wound that we don't want a student to have to deal with, so they don't get overwhelmed. But otherwise, let's say this is a good one. It's a through and through injury. It's got entry and exit wound. And so we'll have them start with a tourniquet, and then we go from tourniquet to, all right, you got the tourniquet on there. Can you wound pack it in such a way that we don't get, can we wound pack it in such a way that the fake blood, which is not really going through under a lot of pressure, we're probably going to try to address that so that we can make our students' lives more interesting. But it is pretty good even with just a gravity feed, like keeping people honest. Yeah, it's like surprisingly just for a gravity feed, it keeps people pretty honest.
Yeah, it really you really have to have your packing techniques down. and I'll say this from personal experience, that even stuff like quick clot, Marcellus gauze or whatever sort of impregnated gauze, which is what this is classified as. There's a material. This is kaolin clay that is impregnated into this gauze that encourages clotting. It doesn't make up for poor packing technique. You have to pack correctly. That this is not a crutch that's going to help you if you have.
I can't miss fast enough to win.
Yeah, you have to be really accurate, and you have to identify that bleeding source. And that's another good benefit of these models is you actually have to figure out where that bleed is. And even right now, without like the fluid flow, I'm kind of struggling to find the actual bleeding source. There
Which
it
one
is.
are you on?
I found it.
Yeah.
This one.
Yeah, that one you can actually can find it. The smaller one, I couldn't figure it out, and that's actually a good thing. This one is one we just got. It's just it's a very new product. It was just released from the vendor. They had it like I saw it. And I was like, I must have it. I saw it in the window and I couldn't resist it. On the arm. The arm's a little older production, so you can actually see where the tube comes into the wound cavity, which just puts off a little bit of the verisimilitude, the realism of training. But so it's better that you have to like figure out where the bleeding is rather than going like it's probably coming from that tube, that clear plastic tube that's sticking into the wound. So I'm really happy with that. Like it's a bigger wound cavity than on both these wound cavities on this leg are bigger than the ones that they built into the arm. So you're gonna have to use more gauze. You're gonna have to really be right on top of your wound packing technique. So it's just a better experience.
Yeah.
I wish they had built in simulated bone for this. That would have been nice. I know North American Rescue has their wound in a box stuff, and that's definitely want to play with that.
Limited by the technology of our time.
I mean, that's changing pretty quickly. But yeah, the wound in a box thing, they actually have wounds where they have like a bone fragment part of it where you can pack around that. And
that
don't have that.
More interesting.
Don't have that yet. The primary focus with these is really teaching you guys tourniquet to wound pack, at least hasty tourniquet to either deliberate tourniquet or wound packing. So very important, just because like otherwise you're running all those problems with potentially having to have amputations, causing heart problems, kidney problems. We want to try to reduce that as much as possible. It's a great tech. It's that these are a great technology. It's kind of in a lot of ways an ancient technology. They're a great technology, but like anything, it's a tool. It's not the whole solution.
Yeah.
But you should buy one. You should buy two, so you can practice with the second one. Mark it as a trainer, and instead of like when you're watching whatever you're watching, preferably SAS Road Heroes. We should be what you're watching. Practice with the trainer.
Yeah, absolutely. No, I think that pretty well covers it on the tourniquet aspect of it.
If you want to know whether you've applied it enough, it should be painful. Not because you're cutting off blood flow, but not because you're cutting off blood flow. You got a nerve right here that runs along with your blood vessel. And if you've ever bumped your elbow, your funny bone, it's not funny. That's what that is. The other way is to have like someone, if you know how to check a pulse, right here at the base of your thumb, on the thumb side of your wrist, check it, make sure you can find it. If you can find it, good. Then put the tourniquet on. If you've applied this correctly, you should not be able to feel that tourniquet, feel that pulse.
Another good option, especially if you have a group of people and you're kind of like teaching this stuff to a group of people. A good thing to invest in, and there's tons of things you can do with it. But a Doppler ultrasound, it's a little audible ultrasound device. They use it in podiatry and obstetrics for fetal heart monitoring. Fetal heart monitoring.
Baby's heart
at one at home. My wife used it a bunch with our second kid.
We have fetal heart monitor at home.
We do. But they're really great for checking for blood flow because you're actually listening to the big science word turbidity of the blood flow change as you're applying that tourniquet, and you can hear that audible change. The same way that you get a blood pressure with a stethoscope and a BP cuff is you're actually changing that flow from laminar to turbid, and you're introducing a bunch of turbulence into it, and that's how you can hear it with the blood pressure cuff.
Bernoulli's principle. Puissel's law. I'll stop.
Science stuff.
Science!
And so with that, you can use it to verify that tourniquets have been applied correctly or not. It's a really good kind of, because even sometimes with feeling a pulse, you can get to that point where you're like, maybe, am I not? It's a cheap and easy way to tell whether or not you do or do not have that pulse downstream of that tourniquet, which is for training use the only way that you can tell. When you're applying this for real, tighten it until all bleeding stops.
Yeah.
Like all of it.
I wouldn't invest in something like that unless you are like regularly running training for yourself or other people.
Yeah.
As far as like if you just like the guy sitting in his apartment like just practicing this, just radial pulse is fine.
Yeah, absolutely, 100%.
Like,
Yeah.
Forgive us, we're going to nerd out on our favorite topics.
Yeah, this is
We
kind
like
of
our toys.
Our thing.
Yeah. Anything else on tourniquets other than go get you one?
Not really. I mean, there's so many different options out there now since 2019. Even before there was other commercial options out there, but they did that study and tested them, and you can get that on COTC's website. Deployed Medicine, you can pull up that list of approved tourniquets.
Yeah.
And, I'm sorry, recommended tourniquets, not
so
approved.
Deployed Medicine, you do have to sign in with an email. If you search TCCC.ua because of the nature of the Ukrainians, but they kindly left us an English version as well. There is I'm not I'm not salty about it. I'll stay out of that. But if you go over there, it's a good resource. It's the Defense Health Agency. Defense Health Agency. They put out really good information. Somebody's got it over here on a screen right now. It's very good. It's like it is the definitive resource if you want to look at this stuff. Mech and I are always keeping up with what's the published guidelines right now, and then kind of listening to the conversations about people who are in the know as to what's coming down the line, just so we can kind of stay current because it's always changing.
Constantly. The science is not settled.
There was something. Oh, tourniquets. So there's two basic kinds of tourniquets. There's your tourniquet that requires a windlass, like the cat, and pretty much everything that COTC recommends. And then there's other tourniquets that are just, I don't know how I describe it, repetitive wrap tourniquets. The SWAT tourniquet is one, and then the RATS tourniquet is another. So the issue is those were designed for law enforcement to easily apply and then get to a hospital very soon, very quickly. The problem with that is you may not have access to that for whatever your setting is. The other problem with that is if you are being taken care of in the field and you've been given blood or you've been given fluids and you're responding to that and your blood pressure is rising, what could be a problem with a tourniquet that stop blood flow at a lower blood pressure and we raise their blood pressure?
Yeah, as time goes on, as the adrenaline dump wears away and your blood pressure starts to return to normal post-injury, you're going to see all of the muscles and the tissue start to relax, and the overall circumference of your extremity is going to decrease, and that's going to cause those non-adjustable, non-pneumatic.
You have to take them all the way off again.
You have to unwrap all of them, and that poses a lot of issues because kind of going back to like the old Red Cross first aid classes, like the first clot is the best clot. There is truth to that. I have other problems with some of the Red Cross first aid stuff, but that's a separate. Just come to class if you want to hear me rant about that.
We have opinions.
There is truth to with how the clotting cascade works. There is a clotting factor that actually starts to break down clots in the body, and so once that first clot breaks through, by that time, that clotting factor that breaks down other clots is already out in your bloodstream and can cause issues with building another clot after that first one blows. So also you have the whole other problem with like now they're still bleeding, which is kind of a problem. Blood belongs in the body, specifically in the blood vessels.
Yeah. So I've met retired Special Forces medics, 18 Deltas that really like the SWAT tourniquet, and that's great.
I don't like it.
That's a great thing, but bottom line, the windlass tourniquet is the way to go.
Yeah, the other argument for the SWAT T and the rats was that they're better for use on children, peds, for the medical terminology, and canines. The problem with that is the cat will actually work on an extremity down to 5 inches in circumference, and a toilet paper, the cardboard tube on a toilet paper roll is 5.5 inches in circumference. So even smaller than that, a cat will actually still properly occlude. So you can use it on peds, you can use it on working canines. The other breeds, I don't know the specifics, but for working breed dogs, a cat will more than suffice with treating that blood loss. Same with peds. If their extremities are smaller than 5 inches in circumference, you can do direct pressure and you can do a pressure bandage, and that will more than easily occlude. Because their extremity blood vessels are so close to the surface when they're that little, you can very easily use direct pressure to occlude the blood flow on those. So that answers that problem. You can't just use a tool to fix a training issue, and that's a whole separate argument for a different day.
And if you want to hear us rant about this stuff even more, come out to class. Thanks, guys.
Thank you.